Almala, welcome. Thank you for joining. I'm going to give a few seconds here just for everything to get loaded up and ready to go. Fantastic. So I hope everyone's doing well. It's Sunday night over here at 7 p.m. And I want to first of all, thank everyone for all the birthday wishes. It was my birthday 2 days ago, and I got messages from all of you, and I really appreciate that and thank you. And I feel so fortunate and happy to have such a great group of friends and family. Wherever you are around the country, around the world, I hope that you're safe. There's a lot going on in the world right now and this weekend and everything else. So I also want to thank you for tuning in today. This is basically to talk about cataract surgery and different techniques for cataract surgery. For those of you who do cataract surgery, I hope you find this useful, and I appreciate the comments. And if you have any comments, please log on. Please type them away, and I'm going to try and keep up with all these different platforms. We're streaming on Twitch, YouTube, and Facebook. If you're not interested in cataract surgery, thanks for logging in anyway. And we'll go ahead and get started. And really, this is interactive, so if you have any comments you want to make, or any questions you have, or any suggestions about different techniques that you use, this is a place for us to discuss them and talk about them. Okay, so I'm just going to present one case here of cataract surgery, and we'll go through this, and I'll make commentary as we go through. So this case looks like to have a pretty good dilation. We see that there's anterior cortical changes here, anterior cortical spoking, and which goes through the center of the pupillary axis, and this can be really cause a lot of glare for patients. So we make the paracentesis incision, and then we go in with viscoelastic and inflate the eye. I also put in preservative-free lidocaine before that. I stabilize the globe using 0.12 forceps. Those of you who have seen my videos know that I really like that technique. And then I use a 2.4 millimeter keratome blade. By stabilizing the globe with the 0.12 forceps like that, you really get to have good control of what's going on. You don't have to worry about the patients moving or looking one way or the other while you're in the middle of trying to do your capsulorhexis, and it really does give you a lot of confidence as you do this part of the procedure. I use a cystotome. I know a lot of you don't use a cystotome, but I still like to use a cystotome to start out my capsulorhexis, and then I use these cross-action Etrata forceps to complete the capsulorhexis. I usually try and go for about maybe a little bit over 5 millimeter capsulorhexis. Okay, for this part, we're doing hydrodissection. And before I hydrodissect, I want to tent up on the anterior capsule, and then I also hydrodelineate. Very important to tent up. That's how you separate the cortex from the capsule, and it can make the surgery much easier to do later on. I go in with my phaco handpiece, and I immediately basically carve out a central core here, and that's what I'm going to use to bury my phaco tip and then do phaco chop. So I reach around the equator, I pull the second instrument towards the center, towards the phaco probe, and that enables me to chop. And I really like this technique a lot. I developed it started developing during my fellowship and refined it during my first few years of practice. I used to use a Connor wand, believe it or not, which actually you can use to use this technique, and I felt safer using it. Now I use this blunt tip Nikkeman chopper to do it. And you can see that the pieces do come out quite readily. I use the You can see I kind of manually move the phaco tip as I'm doing that. I've just found that that really makes the procedure a little bit more efficient. And then for when I come to remove the last pieces here, I want to protect the posterior capsule. This is a blunt tip chopper, but I still like to rotate it sideways. So if the capsule does come up, it's against the back part of the chopper. So right there, all I'm doing is checking for pieces at the paracentesis. So we've gotten the nucleus out. Most of the cortex is already out. There still is a little bit of cortex here. I do BSS at the paracentesis just to clear out any nuclear material that may be hiding there. It saves a little bit of time at the end of the surgery. And then we go in with the irrigation aspiration handpiece to remove the remaining cortical material. So that's that being removed, and fairly straightforward there with the cortical material. I engage it, and then I pull towards the center of the lens, towards the center of the nucleus. Good. And so, really important to do a good irrigation aspiration, a good cortical cleanup. We don't want to leave any cortex behind if possible. And here it looks like I'm doing a little bit of capsular polish with the back of the silicone tipped IA, which I'll sometimes do. But typically I like to use the this instrument here for the to polish the central posterior capsule, which is the silicone tipped Terry squeegee. There wasn't too much there to polish with that, and now I'm going to inject viscoelastic. I'm going to inject a cohesive viscoelastic in preparation for insertion of the intraocular lens. Let's see here. Okay, we injected the viscoelastic. We injected the intraocular lens. We rotated the intraocular lens. Oh, this looks like a procedure with a MIGS device. So what I did here is I injected viscoelastic in the anterior chamber to basically pressurize the anterior chamber, and then I put Viscoat on the cornea. We're going to use that to couple the lens. And here what I'm doing is rotating the scope while my assistant is basically cutting the tape that's holding the patient's head in place. I rotate the patient's head away from me, and I rotate the microscope. And we're just going to spend just a little bit of time here kind of getting things aligned and in focus. Obviously, this is an unedited video. Typically, when I get these all nice and pretty for YouTube, we edit all this out. But this is a live stream, so we get a chance to talk and discuss some of these things as we go through them. So we got a gonial lens in place. We're looking at the nasal angle under direct gonioscopic visualization. Actually, I'm not sure which MIGS device we're using here. It looks like we're doing the iStent Inject. We retract the sleeve and we get ready to place the first of two iStent Injects here. Typically I like to zoom in, so that should be happening fairly soon. There we go. And then I insert the trocar into the trabecular meshwork and release the first iStent Inject. I like that one. We're already seeing some heme coming through there. I'm not sure how well this is coming through the live stream resolution video, but I have a video of this on YouTube, I believe. And then we put in the second one. And there we go. We press the button, come back, and that looks nice as well. So we have two in place. We have heme coming out of both stents. I'm happy with the fixation. I'm happy with the placement here. But sometimes I'll go in just to inject a little bit of viscoelastics just to check and make sure. So that one looks good. We'll check the other one here. That one looks pretty good as well. It's out a little bit. I may try to tap it in. Yeah, so it looks like there. I just kind of realign it, and I'm happy with that. I have not had one of these, knock on wood, displace or really be an issue or a problem post-operatively. So I'm happy with the position of both of them. And now, once I'm done checking, we'll rotate everything back into the primary position. Very good. We'll rotate everything back into the primary position now. Good. And so now we're just going to go in with irrigation aspiration and remove the remaining viscoelastic from the eye. That's my assistant just removing the viscoelastic from the corneal surface so we get a better view. And now we're going in with irrigation aspiration. This is the first time I've gone in, so I'm going to go ahead and remove the viscoelastic from behind the lens and from in front of the lens. And we'll remove the remaining viscoelastic. I like the IOL. It's in good position. I'm not seeing too much in the way of cortical material. I see a stria there in the posterior capsule, which means that the IOL is in good position, but I can also directly visualize that as well. I can see the capsular edge overlapping the optic 360 degrees. That's pretty much what we're looking for. So we've done cataract surgery, we've done the iStent inject. Now I'm going to hydrate the main wound. This is a self-sealing incision. And then we're going to hydrate the paracentesis, recenter the IOL, make sure we're happy with that. We've got some air bubbles that went in there with the BSS, and those are fine. Those are not an issue at all. And that's really about it. I believe for this case we'll check the wounds, which is not visible here on screen, and then I check the pressure just with the back of the 30 gauge. I check the intraocular pressure with the back of the 30 gauge cannula. And that's really about it for the case. I depress on the globe, just make sure the wounds are watertight. And this patient has just had a successful cataract surgery with an iStent Inject. So really, you know, that was just a case of cataract surgery with the iStent Inject. We saw the technique that I used to remove the nucleus, and that case went really well. Really had no issues there. I have, you know, a huge library of cases that I'm going to go through and try and go through these weekly. If you have requests for something you'd like to see, please let me know. I have certainly a library of mixed cases, minimally invasive glaucoma surgeries. I have small pupil cases, mature cataracts, IOL exchanges, IOL haptic amputations. I try to record cases when I'm operating. I'm not as good as that as I used to be in the past. I think it's especially, you know, I think it's you know, as far as your own personal development as a surgeon, I highly encourage, if you have the capability to record cases regularly and just spend, you know, a little bit of time on the weekend going through your cases. You'd be surprised. For me, I certainly was surprised, and I realized, I asked myself, why am I spending so much time doing this maneuver, or why am I doing this maneuver, or this may be redundant, or there may be an easier way to do this or a faster way to do this. We're always looking for improvement, and I think recording your cases and taking the time to review your cases is a great step. The other thing is there's so much in terms of resources now on YouTube and iTube and all these different sites that have cataract surgery cases. And I think it's nice to be able to review those and learn from our colleagues. Certainly, I try at least once a week to watch videos and learn from other surgeons and what they do. And it's amazing, really, how just you pick up little things here and there, which make your surgery safer and perhaps more efficient as well. So that's really about it. Feel free to reach out. You can reach me on Instagram or Facebook or on YouTube. It's IMD76, EYEMD76 on Instagram and YouTube, actually. So I hope you enjoy the rest of your Sunday. Hope you have a good week, and we'll talk again next week.